So Sandy Magaña, PhD, MSW, holds the professorship in autism and neurodevelopmental disabilities in the Steve Hicks School of Social Work. She received a Master of Social Work from California State University, San Bernardino, and her PhD from the Heller Graduate School of Social Policy at, I'm going to mess that up, Sandy, Brandeis University?
Brandeis.
Brandeis University, I was close. Magaña completed postdoctoral training from the NICHD-funded postdoctoral program in developmental disabilities research at the Weizmann Center, University of Wisconsin-Madison. She was a faculty member in the UW-Madison School of Social Work for 12 years and later served as a professor at the Department of Disability and Human Development at the University of Illinois at Chicago. Her current research includes investigating racial and ethnic disparities among children with autism and developmental disabilities and developing culturally relevant interventions to address these disparities. She has received funding for her research from the National Institute of Mental Health, National Institute on Aging, National Institute of Child Health and Human Development, and National Institute on Disability, Independent Living, and Rehabilitation Research. So please join me in welcoming Dr. Sandy Magaña, our keynote speaker. She's speaking about getting to equity, identifying and reducing disparities for Latino children with ASD. Thank you for being here, Sandy.
Thank you so much for inviting me. And as I was mentioning, we were chatting a little bit before, I really wish I could be there in Atlanta to join y'all, but we have some really interesting circumstances that we're all dealing with. But this is just amazing, you know, the technology and being able to set this all up with all of the different bells and whistles that you guys did. I mean, it's just really amazing. And I feel like I'm kind of nervous, even though, you know, it's remote. I feel even more nervous than I was there in person. So I'm going to give you an overview of what I'm going to talk about. I want to first define health disparities and health equity. I know that's the theme of the day. And so and nice to have some definitions. And then I'm going to talk about, mostly I'm going to talk about my research relating to Latino families. Not to say that my research is all there is out there. There's a lot of great people who are doing equity research, health disparities research in the autism field. I'm really happy to see that that's a growing area of research. So I'm going to talk about my research related to sort of detecting disparities, understanding why those disparities exist, and then reducing disparities. So that's moving towards equity. And then questions and discussion at the end I'm really excited about. So first of all, I just want you to think about this for a minute. Like, what are health disparities? Just think real quickly, what do you think health disparities are? And the first thing I want to say is that not all differences are health disparities. So a lot of times people will point to differences in different outcomes and call them disparities. So if you think about differences like between people who are children and people who are older adults, right? Those are definite differences having to do with biological factors and sort of the life course, and so those would not be considered disparities. The fact that older adults have more chronic health conditions than children is not a disparity, but it's a difference that's important to think about. So health disparities are health differences that adversely affect socially disadvantaged groups. And I think this is a definition that Braverman has written about. I think it's really important. And it's generally related to race, ethnicity, religion, nationality, socioeconomic resources or position, you know, areas in which people are often marginalized, and really relates to the social determinants of health, so not just the biological factors related to health. So health equity then, a lot of times people will say, why do I prefer to use equity over disparities, or, might choose one or the other, but they're both important and they're both related. So equity is the value underlying commitment to reduce and ultimately eliminate health disparities. So you find disparities, you want to basically increase opportunities so everybody could be healthier, have the same outcomes, right? And so it really does relate to disparities. And it does, this is an important point, it requires concerted effort to achieve more equity. I gotta move I can't see what I'm doing here. Okay, to achieve more rapid improvements among those who are worse off. So if we think about, for example, what's going on now with COVID, right? There are health disparities, existing health disparities right now, particularly that impact minority adults or children, where they have worse health outcomes, more chronic health conditions, right? And currently we're finding that those disparities are exacerbated under COVID because COVID tends to affect more negatively people who have those chronic health conditions or comorbidities. So you're really seeing those disparities right now in the current environment. And then when you think about concerted effort to achieve more improvement, right? That's why we have to target particular communities, those that are more disadvantaged or experiencing COVID even more. And so that means putting more resources into those communities to really kind of equalize the opportunities. And so I like this table. You guys have probably seen this before, this depiction, because it shows sort of the difference between equality and equity, because that's another thing that is important to distinguish. So equality means that everybody gets the same thing, right? And so you can see in this picture, they all have the same level of support or the same soapbox under them, but it doesn't, people who are more vulnerable. So if you think of that small child, is not able to reach the apples. So equality does not mean equity for that person. In order for everybody to get the same outcome, which is to reach the apple, you might need to give more supports to people who need it more. And that's easy to think about too in relationship to disability, right? Because we know people with disabilities need certain accommodations and supports in order to get the same outcomes that people that don't have disabilities have. And so providing more supports can help equalize that for people with disabilities, but then also if you're talking about racial and ethnic communities, providing more specific supports to those communities is going to be really important. But first you have to find out what the needs and barriers are. And so I like this model, this framework, research framework for disparities. So it has this categories of detecting. So first you have to identify what the disparities are. Understanding, you need to understand what are the, what are the contributing factors. And I like that way they have contributing factors can be at the patient individual level, provider level, clinical encounter, or healthcare system. I mean, it's broader than that even because you can think about society and community, not just the healthcare system as sort of the macro end of it. And then reducing disparities. So what are the interventions you're gonna do? How are you gonna evaluate them? How are you gonna translate and disseminate that? And also policy, at the policy level, you can do a lot to reduce disparities. So those are different ways to think about it. So I'm gonna first talk about detecting disparities, but I wanna first talk about prevalence or so-called prevalence of across race and ethnicity according to the CDC study or surveillance studies that have been done. And I will say, so you see these differences, you can ask, is this a disparity or a difference, right? So if you look here, you can see that the Hispanic Latino group are significantly less identified with an autism spectrum disorder compared to to whites especially. In the past, African Americans have also been underidentified, and if you broke this data down by state, you would find in some states African Americans are underidentified, in other states they're not, so it kind of rounds out to this. There's been some improvement over time in identification for both Latinos and African Americans. So is this a disparity? I would say it's a contributing factor to disparities because what we're seeing here, we don't have any reason to believe that Hispanics get autism less than the general population or than whites, right? There's no data that shows that. And so what we're likely seeing here is that they're being under-identified. And so that means that children who have autism do not get that diagnosis. And there are consequences to that, right? Particularly in our system where having a diagnosis really means a lot for services. And so for that reason, it can contribute to disparities. The chart below basically shows the percent of children who were identified with autism that also have intellectual disability. And you can see that that for whites, it's 22%, for Latinos, 35%, for African Americans, 44%. Now that does not mean that out of all the kids with autism in those groups, that's the actual percentage. It means that out of all the kids that were identified in their surveillance, they did. And I think there's a lot of research to be done about that, right? Because we've seen over time the growth of people being diagnosed with autism, and also the growth of inclusion of more high functioning or people that maybe wouldn't have been diagnosed with autism in the past being diagnosed. And so a lot of times high functioning gets interchanged with the idea of intellectual disability. So you could say that there are more people who don't have intellectual disability that are being identified over time. Let's put it that way. But that seems to be more true in the white population than in the Latino or Black population. So a lot of times, I know in research that I've done with Latinos, the people who are in the service system or that are actually identified are the ones that are more severe or have more challenges. So they often don't even get to the radar. So I think that might help explain some of those differences there. So I'm gonna talk about, well, so this is just continuing on the Center for Disease Control, just looking over time with Latinos. So you can see that they've been significantly under-identified since 2002. So every time they've done these surveillance studies, they've been significantly under-identified. Now it did go up, in 2010, you see it at 1%, still significantly different from whites at that point. But then you see the number increasing for whites since 2010, but not for Latinos. So it's been stabilized at 1% of the population. So you still see that under-identification happening, even though the gap did start to close. So that now I'm going to move on to talk about some studies that I did when I was in Wisconsin. We did a study where we looked at age of diagnosis and a number of disparities in services, because that's, we know that if you get diagnosed later, you're going to miss some windows of services like early intervention. You're going to access services later, and a lot of professionals talk about the importance of getting services early to really impact outcomes later in life. And so what we see in this chart, and this was a sample of Latino, mostly immigrant families in Wisconsin compared to whites, and we can see that they kind of noticed something at the same age, and then they told the provider there's a little difference there, but it wasn't significant. So about the same age, they told their provider about their concerns. But then when you got to when they actually got a diagnosis, it was a significant difference of close to a year. So, so we have to wonder what's going on between telling the provider and, when they actually get a diagnosis. There's this sort of lag. And I think this data is important because I hear a lot of anecdotal stories about how there's a lot of stigma in the Latino community, so they don't notice that there's a problem. But this data, and this is not a representative study, but this data shows that they do notice, the families do notice something, and they do tell their providers. So I think it's important to recognize that. So then looking at some of the services in Wisconsin, so the autism waiver is basically, is a pretty robust program in Wisconsin. I don't know if it's the same now, but basically it's Medicaid waiver. So you have to be on Medicaid to get this service, but it only provides funding for ABA. So really we're talking about ABA therapy, applied behavioral analysis, which is shown to be a very effective behavioral intervention for children with autism. And so they would only provide funding for evidence-based treatment, which at the time was ABA. So what this is showing is that the white children were receiving way more ABA than the Latino children, even though it was a Medicaid program, right? And most of the Latino children were low income. The white children were actually more middle income. And then we see the birth to 3, the big difference. And so you might expect that because of the age that they were diagnosed. They were on average diagnosed around 4. And so they're missing that window of birth to 3 and not getting into the birth to 3 program. And maybe they're not being referred, before their diagnosis for challenges that may be observed as well. You get to early childhood, that's when it starts to level off. So the early childhood programs provided through the IDEA Act, they're getting recognized at age 4. So that makes sense that they're going to be maybe being able to access that. And then special ed, there was no difference there either. So they are, by the time they get in school, then they're getting special ed. Now that's not saying the quality of special ed. I know a lot of you probably have a lot of stories about special education and the quality that people get. So this is just whether they get it or not. So one of the things we wanted to find out is where did they, after they did get a diagnosis, where did they get more information? Because there's information out there. There's good information. There's bad information. There's information in English mostly, some information in Spanish. And so we see here is that the most significant difference between Latinos and whites was on books and magazines and internet. So Latinos were less likely to get more information on the internet. And I think there's more information now in Spanish on the internet, but still not that much. At that time, it was even less. They're also, the Latinos tend to get information from healthcare professionals, which is good. And from their educational professionals, which is good. But you can see there, if you add all those together, there's big differences in where they get any information about autism, even once they're diagnosed. So I'm gonna move on to talk about a different study. So that study was not a representative sample, but we wanted to look at representative national data. And so this study is from the National Survey of Children with Special Healthcare Needs. Let me see if this is the, I think I wanted to start here. So the 2006 data, so National Survey of Children with Special Healthcare Needs collected data every 4 years. And they're no longer, they're now subsumed under the National Survey of Children's Health, but so that actual data set doesn't exist anymore, but we were looking at 2006 data and looking at healthcare. So not things like ABA, but seeing a doctor, seeing a pediatrician and so on. And these were parent reports. So basically we can see significant differences in insurance for Latino children. They were more likely to say they did not have insurance. They were also more likely to say that they didn't have a usual source of care. And that's important to have a regular pediatrician that you're going to. And so they're less likely to have that. And then in terms of utilization of services, they had more difficulty using services and problems getting referrals. So those are disparities in sort of healthcare related access and utilization. And then we looked at disparities in quality of care. And these are things that are really important for quality, right? So if your provider makes you feel like a partner or spends time with you, they're sensitive to your family values, they listen to you, those are really important things. And so we found here, and this is 2010 data, but we looked at 2006 data and 2010 data. And we wanted to see if there were any changes. And so I'm just showing you the 2010 data right now, but you can see that there are significant differences, and particularly for African Americans compared to whites. There were more differences in things like, in most of these things, African Americans were even less likely than whites, and Latinos were also less likely than whites to report that their providers did these things with them. And so it was very similar findings with the 2006 data. And in this analysis, what we did is we pulled all the data and sort of controlled for time to see if there was any difference, and we didn't find it. So, you know, we wanted to know whether between 2006 and 2010, you know, were there policies that were being implemented and put in place that maybe would lead to better outcomes, and we didn't find that at this time. So that is about quality of healthcare, which is very important for children. So there was another data set, national data set called Pathways. And that data set was basically taking from the 2010 National Survey of Children with Special Healthcare Needs, and they did another survey in 2011 of parents of children that had either developmental disabilities or autism specifically, not all special healthcare needs. And they also looked at specialty services, so not just healthcare services, so things like receiving OT and behavioral therapy, social skills, those kinds of things they looked at. And so we did report on all of those different services. And what we found is that we're looking at the issue of severity, because you would expect that children who have more severe disability are going to need more services, you know, and so you would expect that they would get more services if they had higher rates of disability or more severely affected, right? And so what we found is that for the white families, which is the columns on the left, that was true. That if they were more affected, they did receive more services. But for the Latino families, if they were more affected, they did not receive more services. So that was another disparity that we found just looking at that additional data. And what was interesting about this data set is that it was completely in English. So a lot of times the previous data did include Spanish speaking as well as English speaking Latinos. And we know that there are a lot of barriers to getting services, for language barriers for immigrant families and families where the parents only speak Spanish, right? This data, that all the surveys were done in English. So even with just English speaking Latinos, we found these disparities. So then I want to talk about a little about understanding disparities. And I will say, I haven't done a lot of work in this area. I think qualitative work is really important to get at understanding disparities. And there are people who do that qualitative work. I know Jennifer Singh does a lot of that, and other people have done that with Latinos like Katie Zuckerman and others. I think it's really important. You can use quantitative or qualitative data to get to understanding sort of what the factors are. What are the contributing factors to disparities? But this study, I felt kind of leads in that direction of helping to explain. So we used the Pathways data for this as well. And we were looking at children only 11 years old and younger that were in that data set. And we wanted to know, did the provider response have anything to do with service use? You know, did that impact service use for Latinos or compared to whites? And this just shows you that whites in general did receive more specialty services. That was a significant difference. And then we looked at provider response. So there's active response. We categorized active response as things like doing a screening or referring to a specialist, or talking to the family about talking to their school for services. So that would be an active response of a pediatrician to a parent who's bringing up, you know, a concern. And then a non-active response were things like saying things like, oh, let's wait and see, or he'll grow out of it, or just not really, you know, just kind of a passive sort of response. So what's interesting here is that we didn't find, these were not significant differences, but in general, whites reported that the doctors had more both active responses and non-active responses, right? So we're not seeing differences, you know, where the doctors are telling Latinos to wait and see more than they are whites. So, you know, that if you think about the issue of equity versus equalities, they're treating them basically equal here. They're not, you know, saying to one group worse outcomes. But one of the things that we did find is that if the doctor had any kind of non-active response, they could have active responses too. The Latino children receive less services than white children. And so this chart is showing that number one represents that they had this sort of passive non-active response, and 0 is that they didn't report that any passive response. And so you can see that it makes a difference for Latino families if the doctor gives any kind of passive response, even if they had an active response as well. And so I think, you know, that's an important takeaway, because it really kind of highlights the equity versus equality issue. So maybe treating them equally is not what's important. It's important to identify where do Latinos need more support. So it may be that providers or pediatricians should be giving Latinos active responses all the time. They should be very, you know, proactive in making sure they're getting screened, making sure they get referrals, and not skipping a beat there. And that might make a difference. And this is another study. I know I'm going through a lot of different studies. I'm happy to talk to anybody about the details of them, or these are published studies, so I can share with you articles about them. So one of the things that may also contribute to disparities is the measures that we use to identify and diagnose. And so maybe you know, this could be a contributing factor to why Latino children are underdiagnosed if the instruments that we're using are not culturally adapted or culturally valid. And so we wanted to look at this with the ADIR, which is the Autism Diagnostic Interview Revised. It's a sort of considered a gold standard. I mean, not a lot of clinics use it because it does take a lot of time, but ideally having an interview, you know, where you can get at the history with the families, and having an observation are sort of the gold standards. So the ADOS being the observation tool that a lot of families use. And so we were looking specifically at the ADIR because that involves a lot of parent interviewing. It's not just observation. And so there could be some interpretation issues going on. Now the ADIR is used worldwide. It's translated into 17 different languages, but these are translations of the text, not validation. And I will say the Spanish version went through a lot of iterations, the official Spanish version, because you have to purchase these instruments. So we used the so-called official Spanish version, and My understanding of the history, because I know the person in Chicago who did the original translation, she's from Argentina, but she's worked a lot with Latino families in the Chicago area from different backgrounds. But then it got, somehow Spain got involved. And so the official Spanish version is actually sold through a company in Spain. And so there's a lot of Spanish sort of references there. I mean, Spain Spanish versus Latin American Spanish. There's different people who speak Spanish, no differences in just words and languages and stuff. So it kind of is more in that direction of Spain. Like even the toys or games that children play are more based out of Spain. So interesting, but they never did a validation study. And so these are some studies that have looked at things like sensitivity, which means basically that all children who have a diagnosis of autism are diagnosed with this instrument with autism, right? So specificity is more about ruling out. So children who don't have a diagnosis of autism who get identified with this instrument with autism, would fit under specificity. And so in the United States, the original study, validation study that was done by Kathy Lord and colleagues had very high sensitivity and specificity. And you can see in other countries, there are different levels, right? So Japan had very high rates, Greece, not so high. The sensitivity is lower, the specificity even lower. In Finland, high on sensitivity, low on specificity. So there haven't been a lot of validation studies in different languages, but these are some that we could find. And so what we did is, these are some of the factors that can contribute to cultural differences, right? In terms of diagnosis, things like eye contact could be different across different cultures, how people interact socially, gestures, their knowledge about child development or how they consider child development, language proficiency, and I'm going to talk a little more about that, can make a difference. And the best practice is to ensure cultural equivalence of content, right? Validate it with a culture and establish culture-specific norms. However, I don't know very many instruments that actually have had that process done. So for this study, we modeled what Kathy Lord did, basically. We had almost half of the children who had an official clinical ASD diagnosis and half the children who had a developmental disability diagnosis, and basically compared those two groups to German sensitivity and specificity. They were very similar to each other in terms of the demographic variables. These are the children were on average age 9 in this study. Most of the children were US born, whereas as you can see here, the majority of the parents, the mothers is who we primarily interviewed were foreign born, and most of them being of Mexican descent. And the interviews were all conducted in Spanish. We used the Spanish version, so the primary language of the families were mostly Spanish of the parents. And so one of the things we found, we did this during when DSM-4 was still in effect, right? And so DSM-4 has these 4 categories, sort of domains: social reciprocity, communication, and that's divided into nonverbal sort of gestures and verbal communication, and then restricted repetitive behaviors. And what we found is that there were significant differences between the autism and the DD group on social reciprocity and restricted repetitive behaviors, but not on the language variables. And so we did a little more exploration of that issue, and we only chose the children out of the sample that were verbal to look at this. So it's very small numbers, but what we found is interesting. By concordant, what we mean is parents who spoke Spanish and their child also spoke Spanish, right? And that was mainly how they communicated. Whereas discordant, we were looking at parents who spoke Spanish, where the children maybe spoke more English than Spanish. And so the parents may not have a good understanding of how the child is communicating, but have some ideas, right? So that's what we're trying to look at. And what's interesting here is that we found that so a higher score on these domains means more impairment. So if the parent knows that how the child communicates because they both speak Spanish, the parents reported more impairment for the autism group in nonverbal and verbal communication, nonverbal being gestures and so on, right? Whereas if the parent and child had different languages that they were mostly speaking, the parent rated the impairment as lower. So personally, I would go with the parent who knew more about their child's language. So that's probably a more realistic assessment of the child's language. Whereas with the DD group, it was the opposite. So I don't know why that is, but parents who were concordant actually rated less impairment for their DD child, and discordant rated more impairment. But the bottom line of that analysis is that we can't really rely on those language, those language domains. Now that's been changed for the DSM-5, so I'm going to show you some data where we looked at it related to the DSM-5. But in general, I think the takeaway is that you have to really understand, if you're doing an assessment with a child for autism, you really need to understand the language level of the child, where, are they speaking mostly English or Spanish, and of the parent, so that if you're asking the parent about the language of the child, you can decide, what information you need to get more observation on, and so on. So if we look at the overall clinical validity, we found that our sensitivity and specificity rates are fairly low compared to, just a reminder, for the original study was 96 and 92%, and ours are 69 and 76%. So not super valid. There's some validity there, right? So then we looked at the DSM-5 criteria. And so that, as you probably remember, has two main domains. There's social communication and restrictive repetitive behaviors. And so we're seeing that both of those categories did distinguish between the DD and the autism group. And so probably by not having the language category be on its own, that actually helps with the diagnosis for Latino children. And then we found that the sensitivity was higher using the DSM-5 criteria, which is interesting. I mean, we could get into a whole conversation about that. Some studies have shown that there's less sensitivity with the DSM-5 when they've done reanalysis of other populations. So, but maybe for Latinos, it's actually better. It's including more kids who actually have an autism diagnosis than the previous version. So that just gets us to a little bit about why there might be some disparities and work that we need to do, right? We need to do a lot of work in validating these different instruments. So now I'm going to move on to talk about reducing disparities. I think reducing disparities, it's important to keep in mind that there are different levels, different kinds of interventions that you could do, right? You could use culturally tailored interventions to help empower families on an individual and family level to reduce some disparities. You can provide interventions on the provider level. So if there is bias or discrimination going on, or you need to train providers how to be more proactive with certain groups, so that would be an area of intervention. And then there's policy level interventions. Like, for example, I'll just give an example of something that always stands out. Like when I was in Illinois and also in Texas, while they have insurance mandates for ABA therapy, they didn't have, Medicaid did not cover ABA. So that just creates disparity, right? Because it means that children who are low income and poor are less likely to receive ABA in those areas. Now in Texas, they just passed, in our last legislative session, they passed a law saying that Medicaid has to cover ABA, but it hasn't been implemented yet. So it's still a problem. Now, it doesn't resolve all problems, right? Because I don't know how it is in Atlanta, whether Medicaid covers ABA or not. Patricia was gonna comment on that maybe. Do you know, Patricia? I don't know if I have to do something with somebody who raises a hand, but feel free to put that in the comment section. So once there are other barriers. Once Medicaid is covered, then you have an issue of Medicaid has low reimbursement, and so then providers don't want to take Medicaid. So those are other sort of macro level issues that have to be addressed. So I'm going to talk about a study that I've been involved in, that I've been working on for the last several years, that's really working at that family individual level. Parents taking action. So we created this intervention to address disparities for Latino parents of kids with autism. And I'm going to talk more about this tomorrow. For those of you who will be on the talk tomorrow, we're going to talk about culturally tailoring interventions. So I'll get more into detail about why it's important to have like a stakeholders involved or advisory committee involved. And then I'll talk a little bit about what the ecological validity framework is, and using community health workers or promotoras de salud. So this is the curriculum that we developed through stakeholder involvement. We have some psychoeducation because we found that many of our families just don't have the information. As you saw in one of the previous slides, they don't get information about autism. And so really getting into some doctoral information about child development and how it relates to autism symptoms, and then autism, and then what works. Basically, what does the evidence show about what interventions are effective? People never get that information. And then we have some advocacy pieces, so and also parent support. So that's really important in terms of helping parents to understand how to advocate for services, either in the community or in schools. And then reducing stress, because we know it can be stressful raising children who have challenging behaviors and other things, and talking about autism to others and social support is another area that can relate to stress, right? So then we also, and I will say Wendy Mihalacek, who's a BCBA, she's a professor at University of Oregon. We both met in Wisconsin, actually. We were both there together. And she really helped us develop a lot of these evidence-based strategy pieces of our curriculum. And so integrating sort of naturalistic ABA approaches and other social stories and other kinds of things that have evidence. So we talk about play and the importance of play, creating opportunities for communication, and making friends, and then understanding reducing challenging behavior. So in this intervention, it's a psychoeducation intervention, meaning that we're not doing coaching or training with the parents. We're basically providing this education to them. So the child is not involved in this process. And to deliver the intervention, we use promotoras de salud. And so basically, promotoras are widely used in our community health workers in many communities, right? In public health, they use promotoras to help educate families on chronic health conditions or diabetes or heart, other kinds of more health related conditions. And so we decided to use that model with autism. And we made sure that our promotoras were mothers of children with autism because we really wanted them to have that peer element. These are our promotoras in Chicago. Now, they were so great. They worked with me for over 4 years. There's a cake there because they finished their training, so you have to celebrate that. And then these are the promotoras in California. So we did a 2-site study in California and Chicago. We had intensive training. They received at least 32 hours of training. Of course, we made sure and paid them for their time during that training. we created some materials. So we had a promotora manual, which specifically gave instructions to the promotora, and a participant manual that had the same content, but just not all the questions and things that were in the promotora manual. So the way this was structured is they would do weekly home visits. It was a 14-week program. The home visits were 2 hours. The reason for that, they were designed to be 1 hour, but the promotoras wanted the extra time because they do a lot of sharing and talking. They really felt that was important. And then, so we have all these different pieces of it that we, resource guides and other things that we include. And so what we did is we recruited families that had children between 2 and 8 years old, you know, made sure that they were either had a diagnosis of autism or were at risk for autism. And then they were randomized into intervention now or a waitlist intervention later. So 8 months later, after the different evaluations that we did a pre-test, a post-test, 4 months later after the intervention, and then another post-test 4 months after that. So this was our sample. We had 42 people in the intervention, 54 in the control group that we were able to do pre and post tests with, basically. And the only difference between the two groups was education. It was sort of almost significant. So we made sure to control for that in our analyses. So I'm just going to share with you a few of the outcomes and then we'll wrap it up. But we did find that one of the things we're looking at is how comfortable do the parents, the mothers feel about using those evidence-based strategies we were teaching. And we found that they were significantly more confident in using those strategies in the intervention group at the post-test. So the lighter blue is the post-test time. For the control group, there was no difference between pre and post-test. And then how often did they actually use the strategies? Again, significant difference for the intervention group, not the control group. We didn't expect to have child outcomes because we weren't working directly with the children, but we did find some child outcomes. We actually found that impairment in social communication reduced for the intervention group and not for the control group. We also looked at challenging behaviors and we didn't find significant differences in that, I will say. And then to reduce disparities, we wanted to make sure they were getting more evidence-based services. So we found that a significant difference in receiving evidence-based services for the intervention group, but not for the control group. So that was a really important outcome for us. And then this is some analysis we're doing now. We're looking at, okay, over the 3 time points, you know, are they maintaining those changes over time? And so we are finding, for example, with social communication, the intervention group went down, that's the orange one. And then it pretty much maintained over time, whereas there was no change for the control group. And then using strategies, we found the kind of the same. I mean, with the intervention group, it went up at time 2, slightly down at time 3, but it still was significantly higher than it was at baseline. So we're seeing that we had some really good outcomes there. We did find some different outcomes though between California and Chicago, LA and Chicago, where we looked at the family, sort of an empowerment measure, the family outcome scale. And we didn't find differences in that in the Chicago group, but we found significant differences in all the different subcategories and the overall measure for California. So that's something interesting to think about, that things can vary by site. And this is evidence-based services, similar pattern. And so in general, parents were feeling at least more confident, more empowered. They're using evidence-based strategies more, which may then lead to child outcomes and accessing more services. We're adapting that, and I'm going to talk more about this tomorrow, adapting and disseminating and adaptation of evidence-based interventions and what we will do for that. And so for this intervention, we do have a group led by Sarah Dababna in Baltimore who has adapted this for the African American community. In California, we actually are using this as part of the regional center to reduce disparities for older kids. So they made some changes so that the curriculum met the needs of older kids. We did a study in Bogota, Colombia, and that was fun. We had some good outcomes. And then there's a graduate student right now who is doing as her dissertation, making adaptations for Chinese Americans in the Chicago area. And we've done different levels of train the trainer with different organizations. So we're always happy to talk to organizations about using the intervention, and so feel free to contact me about that. These are most of the people, probably not all the people that have worked with us on this project, so just to acknowledge them. And so I'm ready for questions. So I don't know, Jareen, if you've got any questions for me?
Thank you so much for all this great information, Dr. Magaña. We really appreciate it. I have two questions that I see in the Q&A. The first question is let's see, when asking, I'm just going to read it verbatim, and let's see if we can pull out exactly what it is this person is asking. I meant, Magaña, when asking, how is better support being given to low-income individuals or communities? So how is better support being given to low-income individuals or communities?
That's a great question. I mean, I don't know what the answer is in terms of what's actually going on right now, but it's a great question to think about in terms of how do we give better support to low-income communities, right? And I bet you we're going to hear from people in the panel and throughout the conference about how people are doing this, and I'd be excited to hear what's going on in Georgia for that. But I think it is important to you have to look at all different things like awareness about autism, right? Are you tailoring your awareness programs for different communities? I think that's an important thing to do, making sure you're reaching communities in the way that they can be reached. So there's a lot of cultural tailoring that can go on around that. And then educating providers is super important. So making sure that for our Spanish-speaking families, that there are bilingual providers and using interpreters when there's not, but making sure that you're really communicating, what are the strategy, what are the programs that these children need to be referred to, and being very proactive, as we mentioned before. I think being super proactive and not having a casual, well, let's come back and see me in 6 months and we'll see what happens. Really want to refer people right away if there's any suspicion. I think it's going to be important at that level. And then I think helping people overcome the different barriers to services. A lot of services we put there have barriers, like thinking about the waiver program in Wisconsin. Okay, it was a great program. It provided over 20 hours of ABA for those children that got in, but there are a lot of iterations, a lot of things you had to do to get that program. So first you had to get the diagnosis. And they did hire in the counties, they did hire bilingual service providers that help families through that process. But then the families were required to go get find their own provider and contact your service coordinator and say, this is my provider. Well, the Spanish-speaking families did not get that message. And even if they did get the message, most of the providers in Wisconsin were English-speaking, so they would have had a hard time contacting these providers. And so that's a barrier, right? So we have to be very mindful of those kinds of barriers. So I don't know if I answered your question, but things to think about, I guess.
Thank you, Dr. Magaña. The next question is, what types of essential interventions are used for children diagnosed early with autism?
Well, I think it's super important that they get into the birth to 3 programs, right? So that's early, before 3. And so having a diagnosis before 3, or, I mean, a lot of children are allowed, you know, are able to get into birth 3 programs if they have certain challenges in child development areas, right? And so, but making sure that they get into that even if they don't have a diagnosis is super important. So the birth to 3 programs provides can provide specialized services like OT, PT, depending on the needs of the child, speech and language therapy, education. I'm sure every state and county is different in how they implement that program. So that's one. If you have a diagnosis of autism, you know, a lot of evidence is showing that accessing ABA therapy is very important. And a lot of research is showing parent implemented sort of naturalistic intervention is important. So naturalistic in developmental, I'm not saying it right, but therapy, you know, where parents get trained how to do it. So it is using ABA principles and strategies, but it's doing it in a more naturalistic setting where, you know, you do things like following your child's lead and making sure that you have, you know, that you're engaged in play with your child and so on to help enhance the goals that you're working on, whether it's communication or other things. And so there's a lot of evidence showing that that is very effective, and that parents are the ones that spend the most time with their child, right? And so in addition to accessing actual ABA therapy, getting that training is really important. Now, it is hard for many parents to, you know, think, well, I'm the therapist 24 hours and I have other things I have to do. And so there are a lot of barriers to that too. But I think I would recommend definitely getting into ABA early if you can. If the child has speech and language challenges, that's important. I've observed occupational therapists being very helpful in terms of teaching children self-help skills and removing environmental barriers that the child may have. So I think getting into those services early does help.
Wonderful. Thank you, Dr. Magaña. Okay, next question. Make sure I'm going in order here. We had a question. With COVID-19, has telemedicine taken off in reducing disparities? It's a great question.
That's a great question. Is it reducing or is it increasing disparities? And I think it really depends. I don't know if we have broadband in Atlanta or not, but we definitely don't have free broadband for everyone in Austin, Texas. And so we're actually implementing another intervention I'm going to talk to you about, which is more parent training intervention. And with COVID, we have to switch to telehealth and remote ways. And the families that we started the intervention with before COVID, we called them all and said, do you have internet? Well, probably 1 out of 5 of the families that we called had actual internet in their home. So there's a disparity right there. And then, or contributor to disparities. And then we asked them, did they have unlimited data on their cell phone? Because maybe we could do it over this. Everybody has a smartphone. Most people have smartphones. And most of them did not have unlimited data. So if we did an intervention with them over their smartphone, they're going to be paying for it, with their data. So that can be a problem. Now, I think a lot of schools, because of COVID, have given families access to internet. I don't know to what extent they could use it for this type of intervention. So I think if you're talking about rural families that are middle class and have internet access, yes, that could reduce disparities for rural families. But I think for low-income families, not so much unless we get broadband free, which I think we should do.
Thank you, Dr. Magaña. Another question we had, what are some reasons why behavioral outcomes didn't change with promotora intervention?
I think the reason is because we're not really, although we do cover, we had 2 sessions out of 14 that cover behavioral challenges, right? So we're not doing that every time. The promotoras are not behaviorists, they're not EBA therapists. So they're sharing information with them that that's evidence-based, but they're not showing them how to do it with their child. So I think if you want to get to changing behaviors, you really do have to have that parent and child coaching and interaction. So that's, we're doing a study where we're looking at that, and we'll see. I mean, a lot of people cite each other. I don't know. A lot of people cite research that says that you need to have 24 or maybe 40 hours of ABA therapy to really change behaviors, right? We had somebody in Austin who did this incredible meta-analysis to look at the effects of interventions among just all the interventions that have been done. And there really is not a lot of evidence about the dosage. This is an issue that I'm really concerned, I'm really interested in, because is it 40 hours, is it 20, or can it be less than that, right? Because even 20 hours of ABA therapy is quite a burden for families, right? So they, and especially for low-income families, getting to a clinic and getting that therapy can be really a burden. So can we do research and find that you actually can have an effect with less hours? But you still need that sort of really understanding those principles of ABA and being able to use it is important. But I think the question is still open about what is the right dosage for ABA therapy. But yeah, I mean, to answer your question, our intervention did not do that.
Thank you for that. The next question I have on the list, why do you think that the specificity is so low with Latinx in the DSM-5? What are we calling ASD that is not?
Okay, say that again.
Why do you think that the specificity is so low with Latinx in the DSM-5? And then there's a comma. What are we calling ASD that is not?
I'm not sure I understand the question, but the first part of the question, why is it so low with the DSM-5? And I think it was low for both the DSM-4 and the DSM-5. So meaning that children are being saying they're being diagnosed with autism when they don't really, or at least with the instrument. The instrument is saying they have autism when they don't really have it, according to their clinical diagnosis. So why that is a good question. Yeah, that's a good question. I would love to talk to anybody about that, because I really don't have an answer for that.
Thank you. All right, we have a question from our Facebook Live group. I'm curious if Dr. Magaña has used any measure to assess activation in parents or readiness to participate in intervention.
No, I haven't, and that's a really good. I know that is an important approach, is to make sure that people are ready before you implement an intervention. I mean, I will say that without doing that, we had a very good rate of participation throughout the intervention. And what was really nice about the home visits, we had a very good retention rate. So with home visits, you can make sure that they get the intervention, but they get all the content, right? So all 14 sessions. Now it may take longer because there might be cancellations on the part of the parent, on the part of the promotora, and you have to reschedule, but at least we can ensure they all get the intervention. And I think our retention rate was like 85%. So maybe 15% were not, dropped out of the intervention of total number of people enrolled. Now there were people, when we recruited families, there are probably people who didn't want to do the intervention. So that kind of analysis might be important for that.
We have about 1 more minute, so maybe 2 more questions. Is that okay?
Mm-hmm.
Okay, cool. So let's see. We have one that says, your presentation was awesome. It taught me so much. Thank you. So quick question, and please excuse my ignorance. I'm a Latina myself. It's obvious through all of this research that Latinos get less services / overall attention, but how do we know that ASD isn't less prevalent in Latinos than compared to white?
That is a really good question. And I think that the problem is there's no like blood test, right? There's no way to, the diagnosis is made through observation. And so that's, observing whether symptoms happen, getting parent report and so on. So I guess if we had a blood test, we could compare across race and ethnicity to see if there's less prevalence, but there's really no evidence. I mean, if you look at other countries, low and middle income countries have lower diagnosis rates. Why is that? Is that because the children don't get it? No, it's because they don't have the detection systems, they don't have the services, they don't have the programs. And so we have seen in the United States that as we increased services, we redefine sort of what autism is. We had an increase in autism. So a lot of that information is not trickling down to lower income groups or groups that are marginalized or low and middle income countries. So, those factors probably contribute more to the rate of diagnosis than anything else. But also, if you think of Latinos don't come from one place, right? They come from, I forget, 19 different countries. So you can't say there's some sort of genetic thing going on with Latinos, right? They represent every race and every ethnicity as well. And so to say that Latinos as a group, we have people coming from all these 19 different countries. How can they all be the same from one group? So I think that's another way to think about it.